Namaste. Good morning. Chairman sends his greetings to all the attendees and delegate speakers. As usual, Apollo is on the cutting edge of critical care, patient care and compassionate care. This conference should highlight the importance of treating nervous injuries at an early stage and critically, and to continue the care in the hospital. Thank you. Namaste.
I'm very happy to introduce you to this Apollo Advanced Critical Care CME with special emphasis on the Neuro Critical Care. As we know, Neuro Critical Care, we always say time is brain. So if the patients come very early, we can really get back to them the full quality of life. This conference has got the best of the speakers and the topics are mostly very relevant, and I'm sure you're all going to be benefited by listening to these stalwarts talking on the various aspects of the neurocritical care and the latest remedy, current treatment modalities. So I'm sure you're going to enjoy this CME greatly. Thank you.
So one of the most exciting new developments in the treatment of stroke is endovascular therapy. So endovascular therapy is when you actually pass a catheter through a blood vessel in the leg, in the groin. You pass it all the way into the brain and into the blood clot, which is blocking a blood vessel causing the stroke. And then you deploy what's known as a stent into the blood clot, and you pull back on the stent, and the stent breaks up the blood clot, and the blood flow to the brain is restored. So this is a treatment that's really quite new. It's really been shown to have a very strong benefit for stroke patients when it's used within 6 hours of the onset of an ischemic stroke. And that's when there's a blood clot in the brain, blocking of blood flow. And so this should become the standard of care in the treatment of patients with stroke. Patients with stroke should come to hospitals that are capable of providing this treatment, and this treatment should be used as quickly as possible by people who are very skilled in performing the procedure. So these are exciting times, and we really expect many stroke patients to do well today who would not have done well in the past.
Now today here, Apollo Critical Care Division is organizing this unique symposium on critical care in neurosciences, and I am, as a neurosurgeon, was given to talk on subarachnoid hemorrhage because of aneurysmal rupture. Now, what exactly it is, that's what I wanted to tell the common population, is that it's just a sudden bleed in the brain. Now, how does it happen? It happens because of some break or some rupture of a small or a large vessel which is inside the brain. Now, it's very important for us because the conditions is very serious and can lead to severe problem, including death. It is very important for the common people to know the cause of it. So, first and most important symptoms that the patient presents is with sudden severe headache. They get a headache which they have never experienced before. So they describe it as the worst headache in their life. So it's very important for common people. That's why whenever they are getting this sort of headache or a continuous headache, should definitely see a neurologist or a neurosurgeon to investigate what is the cause of this headache. Because this headache can be a normal headache like a migraine headache, or it can be a very dangerous type of headache which can lead to this type of bleeding in the brain. So it's very important for a common populations to go and seek the doctor's advice for them to investigate to know what is this headache due to. And the commonest investigations that we do is a CT scan. Now, a CT scan nowadays is available, as you know, everywhere. So you can go across the road and get a CT done, even otherwise. And if there is a, there is a bleed, and then it can be detected in the CT scan. And then you have to immediately seek the advice of a specialist doctor, and he would do the necessary investigation and treatment. Sometimes it's a medical treatment, sometimes it's surgical. So if it is a surgical, as I told you, because of rupture of a small weak point from the blood vessels, which is called aneurysm, it can be treated with either surgery, where we put a clip to block the vessel, or it can be treated by the interventional neuroradiologist by putting a catheter into the groin and then slowly take it up to the brain and block that rent, and thereby cure the patient permanently. So both surgical treatment as well as non-surgical treatment is available for this sort of problem, which can cure a patient. So it is important, and the take-home message will be, whenever somebody is having a severe headache, to seek the advice of a specialist doctor to know the cause of headache and not to ignore that. Thank you.
Hello, this is Dr. Praveen Amin. I'm the intensivist at the Bombay Hospital, Mumbai. I have spoken on shared decision making in this conference. Let me give you an overview of the Neuro Critical Care units in this part of the world. It's an upcoming specialty. Neuro Critical Care is seen in large number of metros in India. What we encounter is patients who are extremely sick, who have had strokes, who have had head injuries, who may not be conscious. Most of them are not conscious and may be on life support systems. In a situation like this, we talk about decision making, and the concept of my talk was shared decision making. Shared decision making is a decision which is taken between the treating physician, the medical team in the hospital and in the ICU, family members and surrogate family members, whereby in the discussion, the team, the medical team and the family members discuss treatment options available for the patient who is on life support systems. It is all patients' relative would like their family members to recover completely. Unfortunately, in these disease presentations, some of which can be critically ill patients, which can give rise to severe neurological deficit, and some of them may even die. In a situation when patients have severe neurological illnesses, they may be deaf with some disorders which would make them kind of unresponsive or in a vegetative state, or they may have considerable disability. So area of concern in this group of patients is what is the current guidelines of how do we go approach treating these patients. Some of these patients are so severely injured that they may have in fact irreversible damage, and they may have brain death. These are patients who, once confirmed by a panel of doctors that are brain dead, are potential organ donors, and the team, social worker, all then counsel the members, family members, to see if these members can be potential organ donors and help the society in large. There are some who may not be brain dead, but may have severe injuries to the brain, making them incapacitated and confined to bed, may not be conscious, may not be interacting with family members, basically being in vegetative state. This group of patients unfortunately become a kind of burden on the family because they need continuous care, and costs for looking after such patients clearly increase. Then there is a group who will recover with good intensive care, with good neurocritical care monitoring. Quite a number of these patients may recover, may have slight deficit, but may contribute to society and lead a relatively fairly normal life. And a small group of patients who are severely injured may recover completely and go back to society as such. The laws in India are unlike the laws in the Western world. Here, when it comes to withdrawing or withholding life support systems, we are in a gray area. Once a patient has been resuscitated and put on a ventilator and the condition looks futile, the law is a little gray. We, in this situation, need experts, 3 experts from the Director of Medical Services, appointed by the Director of Medical Services, to examine the patient and take a decision for the surrogates involved in the care, which is family members, as the patient himself cannot take the decision. Then this message has, if the family members want to withdraw or withhold support, they would have to apply to the court about withholding or withdrawing support. And if a decision is not taken in 15 days, then the clinician may take a decision of withholding or withdrawing support. Treating patients in the neuro-intensive care unit is indeed a complex scenario, and one the treating physician or the neurocritical care physician needs to take a definitive decision in the interest of the patient. So what is called as a collaborative decision in the concept of what is called as shared decision making. And that was the gist of my talk today, whereby we spoke about shared decision making and the role of medical professionals, role of the family and the family surrogates who decides the outcome of these very, very sick patients. Thank you.
Antibiotics remain a very precious resource, and it has had a biggest impact in terms of mortality and morbidity in the history of medical science, and play a very important role in managing neuroinfections, both from the community, let it be in the management of meningitis, which is bacterial meningitis, or a CNS cerebral abscess, or let it be in the management of neurosurgical infections, which could be because of post-traumatic meningitis, or it could be device associated, external ventricular device, or with shunts, ventriculoperitoneal and ventriculoatrial shunts. The key here is to use an appropriate antibiotic. With the community-acquired meningitis and CNS infections, neuroinfections, all you would require is using ceftriaxone. That is what is required. Whereas with neurosurgical infections, which happen not more than 10% of infections with post-operative, where you have to use a combination of vancomycin with cefepime, ceftazidime, or vancomycin with meropenem to get good clinical response. And antimicrobial resistance is a growing problem, so appropriate use of antibiotics is key. And to have an appropriate use of antibiotics, stewardship programs, antimicrobial stewardship programs play a very important role, where the microbiology backup with respect to culture and having data is very important. And infection control in terms of having appropriate hand hygiene as well as contact isolation for resistant pathogens is very important to prevent the spread of these drug resistant pathogens. And with this growing world of antimicrobial resistance, managing infections are proving to be a challenge. Nevertheless, medical community is up to it in managing these with whatever evidence and scientific data that we have at this point of time.
We had a discussion on advanced critical care conference. We had a discussion on head injuries and management of acute management of acute head injuries. We had about 150 participants, and we were able to give an overview of how to initially assess the patients and how to take care of the patients in the initial phase, and what should be done and what should not be done in the initial management of head injuries. Also an overview of what is the Brain Trauma Foundation guidelines was told, and when surgery is indicated, when ventilation is indicated, and such things were discussed today. We also had a good discussion on intracranial pressure monitoring, and we also had a very nice discussion on the various aspects of emergency care and what can be done to minimize the brain damage in head injury. Thank you.
Hello, I'm Dr. Srinivasan Paramasivam. I'm a neurosurgeon. I'm also trained in neuroendovascular procedures. I treat patients with bleeding in the brain, patients with acute stroke. Stroke, as you may all know, it's occlusion of the blood vessels with the clot inside the blood vessels. And today the treatment of stroke has revolutionized medicine. And over the past 10 years, we've been treating patients with acute stroke by going inside the blood vessels and removing the clot so that they have immediate relief of stroke symptoms. But for this to happen, the patient has to come to us very early during the phase of stroke. Usually a patient with a heart attack comes to us immediately because it's a very painful condition and they have severe chest pain. But patients with stroke don't really come to us that early because stroke is a painless disease. But everyone should be aware that stroke is similar to heart attack. It's a brain attack. They should come to us immediately right after stroke so that we could help them remove the clot and help them get better. So this is my information to the public is to create awareness among stroke patients that they should get to the hospital nearest emergency room as soon as they can. Thank you.
Hello everyone, I'm Dr. Sivarajan Thandishwaran. I'm a stroke consultant at the Apollo Main Hospital in Chennai. So acute stroke is going to be a leading healthcare problem in 21st century. But compared to olden days, acute stroke can be treated if someone presents to us in the first few hours of onset of stroke. So apart from intravenous thrombolysis, we also can retrieve the clot using mechanical devices. Currently, the treatment for acute stroke is not well set all across India, and in Apollo Hospital we have created a hyperacute stroke team with an efficient pathway where patients can be treated aggressively, and our outcomes are at par with international centers. Apart from acute stroke, we also have a very good neuro rehab center where we have robotic therapy equipments and also home therapy team who can accompany the patients when they are discharged from hospital. Lifestyle risk factors are the major reason for current increase in stroke incidence in India. So please look after yourself by making sure you are screened for diabetes, high blood pressure, and high cholesterol and other lifestyle risk factors. Please avoid smoking and avoid alcohol excessively. As India is becoming a huge IT sector, nowadays we are seeing a lot of IT professionals getting into increased risk of lifestyle risk factors due to reduced mobility, prolonged sitting, and less activity. So I would encourage all my IT colleagues to be more proactive in looking after the health and get out of your chair every 20 minutes and take a walk for about 20 seconds each 20 minutes. Let's hope we can beat stroke and get our patients back on track as soon as they come to us. Thank you very much.
Okay. My name is Matthew Joseph. I'm a professor of neurosurgery at Christian Medical College, Vellore, with a special interest in trauma. Today I would like to tell you about the management of head injury patients after the ICU. While the patient's in the ICU, the patient gets intensive care there are nurses, there are doctors, there are therapists, there's everything. Once the patient comes out of the ICU, the level of care drops dramatically. And that is where the patient's family, you, have to take over the care. There are a lot of misconceptions about head injury care. After trauma, you need rest. Wrong. After trauma, you need special diet. Wrong. After trauma, you should be allowed to not be irritated. Wrong. Okay? A trauma patient should walk, talk, eat by himself, eat normal diet, talk on the phone, read the newspaper. The more the patient does, the better will be the patient outcome. If you make a patient lie down and just give him fruit juice, the patient will not do well. You make the patient sit, you make the patient walk, you make the patient talk to you, you make the patient read, you make the patient talk on the phone, the patient will do well. So please, if you have somebody who's had a head injury, do not look after them carefully. Treat them like a normal person and the patient will become a normal person. You treat them like a patient, they will remain a patient. Thank you.
My name is Dr. Dhanraj, neurologist in Apollo Hospital. I am going to speak about the status epilepticus. Status epilepticus, it is a severe form of epilepsy in which the patient continues to have convulsions lasting more than 30 minutes here. This is a medical emergency because these patients, quite a few of them die, or even if they survive, they may leave behind a major neurological deficit. Hence, it is always an emergency. The status epilepticus is commonly due to one, the patient who is a known epilepsy patient stopping the anticonvulsant medications abruptly, or there is a patient who drink alcohol, suddenly stop drinking alcohol, or it may be due to a primary problem in the brain like a brain infections or a clot in the brain. Once a person do not regain convulsions from the attack of convulsion, he should be taken to an emergency in the hospital here. In the emergency of this hospital, they may do various blood tests like blood urea, sugar, etc., as well as, if necessarily, a CT scan or MRI. They are given the treatment for the primary cause for the status epilepticus and medications, intravenous medications to control the seizures. The intravenous medication consists of primarily a drug called benzodiazepine called the lorazepam. It is given slowly intravenously, followed by any one of the other drugs like phenytoin, which is given slowly intravenously. If the patient survives, if the patient still gets further attacks, he may have to be given, he may be shifted to an intensive medical care unit. He has to be given certain other anesthetic drugs called midazolam or propofol. In generally, most of the patients, 90% of the patients, the seizures are well controlled with the above two pattern of treatment. If they don't respond, they may have to given certain other special treatments there, I think. So more than this thing, so finally our aim should be to see that the status epilepticus is prevented by taking appropriate treatment. The treatment is very essential because the morbidity and the mortality following the status epilepticus is very high. Thank you.
I'm Dr. Ramakrishnan. I'm the Director of Critical Care Services at Apollo Hospitals in Chennai. There are a lot of people who wonder what critical care is. Although they might have seen ICUs or intensive care unit, they always wonder what does a critical care specialist or an intensivist does, and wonder if we are the same as emergency medicine specialists. There is a significant difference between the emergency room and the intensive care unit. In the emergency room, they give the immediate care or the initial care for any patient who comes with an emergency into a hospital. And subsequent to initial evaluation in the emergency room, the patient may be disposed in different ways. One, they may get admitted to the hospital in a hospital ward. They may be sick enough that they come into an intensive care unit, or they may sometimes be evaluated, observed in the emergency room for some time and be discharged home subsequently. Now, once they come into the ICU or intensive care unit, you would find that different hospitals use different names for this. Like even in our own hospital, We have a cardiothoracic intensive care unit. We have what is called a multidisciplinary critical care unit. We have a coronary care unit. We have something called a high dependency unit, or what we call step down unit. So there are different names that are referred to, and all this refers to focused care. For example, if it is a patient who is undergoing a heart surgery, they may be managed in a cardiothoracic ICU. If a patient comes with a heart attack, they may be managed in a coronary care unit. But if they come with a problem like, let's say, a trauma, or let's say they come with an infection like a pneumonia that requires them to be on a ventilator, or if they come with what we call sepsis, a severe infection that has spread to the bloodstream, or if they come with an overdose or a poisoning or a snake bite, all of these patients may have to be managed or closely monitored in a critical care unit, and they are usually done in a multidisciplinary critical care unit. I want to emphasize that we are very proud of the units, not just because of the world-class infrastructure that we have, but primarily because of the people that we have. And multidisciplinary critical care unit is something that can be delivered world-class only when we have competent people managing it. And we are very proud that as a unit we have doctors who are specially trained in critical care. So we are all critical care specialists, also known as intensivists, and in addition we have nurses dedicated to critical care, so they are also trained in intensive care, and we are supported by several other staff, including respiratory therapists, physiotherapists who have to assist, clinical pharmacologists, dietitians. So it is truly what we call a multidisciplinary care, and we are very proud at Apollo that we have this kind of a world-class critical care service. Again, not just from an infrastructure standpoint, which you could find that it's on par with the rest of the world, but also very proud of the entire team that serves the public.
I'm Dr. Ramesh Venkatraman. I'm one of the consultants, senior consultants in the critical care department, Apollo Hospital, Chennai. What I'm going to talk to you about is what exactly do we do inside a critical care unit. Any patient who has got a life-threatening illness gets admitted to the ICU. It could be a bad infection, it could be a heart attack, it could be a road traffic accident, it could be a stroke, it could be a bleed, it could be anything that threatens their life. Once they come to the ICU, our care in the ICU is basically divided into multiple phases. The first phase is the initial resuscitation and stabilization of the patient. What I mean by that is, we need to make sure this patient is alive for the next half an hour, 1 hour, 2 hours, for us to be able to investigate the reason behind that problem and try to solve it. We need to make sure that if he's lost blood, give him back the blood. If his blood pressure is low, try to get the blood pressure back to normal. If his oxygen level is low, try to get the oxygen level back to normal. We need to do whatever it takes to keep this patient alive for the next few hours to try to understand what is causing the problem and then try to fix it appropriately. So this is the phase where we call it as initial resuscitation and stabilization. Unlike other fields of medicine where we try to get a history, examine the patient and then do some tests and then diagnose, in a critical care unit most often we do not have the time to do it in that kind of a sequence. What we have to do is we have to do things simultaneously. As we resuscitate and stabilize patient, we also run diagnostic tests and try to diagnose and then identify the problem and treat simultaneously at that point of time. In order to stabilize patients, we may have to put them on a ventilator when they are not breathing well. We may have to start medications to keep their blood pressure up. We may have to infuse them with blood and other blood products. We may have to give them back fluids. We may have to dialyze them. We may have to take them to the cardiac cath lab and open up a blocked vessel. We may have to do any one of those or maybe more than one of these simultaneously in these patients to try to stabilize them. Once a reasonable stability is achieved, we then go on to what we call organ support. Is the second phase. There what we try and do is try to maintain the patient's normal body functions as much as possible using artificial machinery. Whatever insult has happened to the patient, his organs are probably damaged and these organs are going to take some time to recover, and during that time we need to be able to take over the organ's function and try to make sure that this patient's organ functions are intact. For example, we continue to leave them on a ventilator, monitor their parameters and make sure that the parameters are almost normal. Similarly, we initiate dialysis, we initiate nutrition, we initiate physiotherapy, we initiate other medications, antibiotics, whatever it takes to support their organs. And most of intensive care is about supporting the organs while the underlying problem is slowly getting resolved. Simultaneously, during the support of the organ, I also want to confirm my diagnosis and try to address that problem. For example, if there is a bleed, I may need to do an endoscopy to try to stop the bleeding and so on. Once the second phase is over, then the last phase is the recovery phase, where we try to wean the patient off all these support systems slowly, get him off the ventilator, get him off the medications that are keeping his blood pressure, allow him to be more awake, interact with the family, try to get him off the dialysis, and then our goal would be to try to prevent secondary complications while helping him recover and getting this patient up and above on the feet and trying to get him out of the ICU as much as possible. And during this entire process, our primary responsibility is also to make sure that the patient's families are treated empathetically, they're given adequate information, and during a time of stress, we try to help them cope with the stress as much as possible. Thank you.
The term cardiac arrest literally means the stopping of the heart. For a layman, it can appear as a drastic event. The stopping of the heart can happen because of many reasons, but the most common cause in the community will be the heart attack. A massive heart attack in the community can cause a sudden standstill of the heart. During that standstill of the heart, since the heart is the main organ which pumps the blood to the brain, since due to the stopping of the heart, the brain is deprived of any blood flow during the cardiac arrest. This, unlike many other tissues, the brain tissue is very, very sensitive to loss of blood supply. So it is going to be dead within 3 to 5 minutes. That is where the early CPR, that is the thumping of the heart, cardiopulmonary resuscitation, plays a vital role. If you start promptly CPR, that is chest compressions, the brain will receive at least 35% of the total blood supply. That can improve the chances of the patient waking up in the future. Other things that matters is how fast you shift the patient to the hospital. The more the time delay, the more the neurological damage, and the patient is not going to wake up after the cardiac arrest. After reaching the hospital, the doctors will continue the CPR, will provide an artificial airway till the pulse and the cardiac activity comes back. Once the cardiac activity comes back, the patient will be shifted to the ICU. In the ICU, it is very, very difficult on day 1 to predict whether this patient will go home walking or whether this patient will wake up without any neurological injury. Most of the time, the major queries of the patient's relatives and attenders are whether the patient will wake up after cardiac arrest. It is very, very difficult there is no tool available as of now to predict whether the patient will wake up at day 1 of cardiac arrest. All we can do is wait for at least 3 days. At the end of 3 days, we can use multiple tools like clinical examination, a CT, a MRI, EEG, SSEP. Multiple tools are available. You have to combine everything together in order to predict that this patient will wake up and go home without any neurological deformity. No single tool can help to guide to predict the neurological recovery. So if at all your loved ones suffer a cardiac arrest, please wait for at least 3 days and to predict whether there is going to be any neurological recovery or not. Thank you.